Hello, everyone. My name is John Snyder. I'm a registered pharmacist and board certified pharmacotherapy specialist who focuses in infectious diseases and antibiotic usage. Every day, I see patients with the label penicillin allergic and the harsh alternative antibiotics often used in their cases. Many of these alternative antibiotics, such as fluoroquinolones and clindamycin, not only have higher rates of adverse drug reactions, but they also may be associated with higher rates of superinfections caused by organisms such as Clostridium difficile. These labels are often a result of penicillin intolerances or side effects rather than a true penicillin allergy. For example, a true allergy to a penicillin is mediated by a person's immune system and will often result in a rash. In severe cases, this rash may be extensive, and a patient may experience swelling of their face, tongue, and throat. An intolerance, on the other hand, is often something like a headache or nausea or diarrhea, which is often self-limiting and will either fade with time or not be present if treated with an alternative penicillin. To stress the importance of understanding what it means to be truly penicillin allergic, today I'll be addressing my top 3 myths associated with a penicillin allergy. So the first myth that we'll be tackling today is that a penicillin allergy is forever. The most common reported drug allergy in the United States is the penicillin allergy. In fact, if we surveyed everyone around you, we'd find that about 10% of the room would report having one. But did you know that multiple studies have examined these results and found that after skin testing, only about 1 in 10 of those 10% of patients, or 1% overall, exhibited any kind of allergic response? Even more interestingly, after 10 years, 80% of the patients that had an allergic, IgE-mediated, or rapid penicillin allergy lost sensitivity to penicillins. This means that they could safely receive treatment with a penicillin again. I can't stress enough how important this is because penicillins are one of the most effective tools in our arsenal to combat bad bacteria. Being mislabeled penicillin allergic means that a patient or one of your loved ones may be receiving a less effective, less tolerated antibiotic unnecessarily. So when it comes to myth number 1, a penicillin allergy is forever, I think we can safely call this myth busted. Most patients after 10 years or more simply do not exhibit an immune response or subsequent allergy to penicillins, and therefore may be able to safely take penicillins again after consultation with their provider. The next myth we'll be tackling is that being labeled penicillin allergic is no big deal because, hey, everyone has one. This is a myth that I've personally heard from both patients and providers, and I think it stems from the notion that we have alternative antibiotics to use in this setting. So really the thought is, what's the harm? As I mentioned previously, penicillins are one of the most effective classes of antibiotics we currently have to work with. They treat skin and soft tissue infections, respiratory infections, urinary tract infections, and many more. They are also some of the best tolerated antibiotics with relatively few side effects compared to their alternatives. Being labeled with a penicillin allergy, patients are often exposed to higher risk antibiotics, and the consequences really do not end there. Penicillin allergic patients have been found to have longer stays in the hospital with more frequent readmissions, and significantly higher rates of resistant infections caused by things like MRSA or methicillin-resistant Staphylococcus aureus, Clostridium difficile, and vancomycin-resistant Enterococcus. So the next time you hear someone say, well, what's the harm in having a penicillin allergy? Now you can tell them. In many cases, reaching for an alternative to a penicillin when one is recommended is like reaching for a chainsaw instead of a butter knife when cutting your peanut butter and jelly. Sure, they'll both get the job done, but you have a significantly higher risk of losing a finger with that chainsaw compared to a butter knife. Our final myth that we'll be discussing today is that if I have a penicillin allergy, I absolutely cannot take any other similar antibiotics. This myth might have its basis built on the old production methods for penicillins and another similar type of beta-lactam antibiotic known as a cephalosporin. It was believed that for many years, due to the two types of antibiotics sharing a similar chemical structure, that if you are allergic to one, you may have a 1 in 10 or 10% chance of being allergic to the other. Decades ago, both antibiotics were actually produced using the same type of fungi, and cross-contamination during the manufacturing process was very high. This cross-contamination was likely the cause of the cross-sensitivity between penicillins and cephalosporins. More recent studies have demonstrated that it is actually the side chains off of the core chemical structure that convey this cross-allergenicity seen between penicillins and cephalosporins, and that a true allergy between the two occurs in less than 1 to 2% of the time. To put it simply, many cephalosporins have different attachments compared to penicillins, and these different attachments convey different risks of developing allergies between the two. This means that a patient can often safely take a cephalosporin even if they have a minor allergy to a penicillin. Now, when it comes to severe life-threatening reactions to penicillins, it is important to avoid cephalosporin antibiotics, unless under the guidance of an experienced provider. The key takeaway here is that if you're labeled penicillin allergic, work with your provider to determine if cephalosporins, a potentially safer alternative antibiotic that is similar to a penicillin, is an appropriate choice for you. So to wrap things up for today, as a pharmacist who is frequently involved in the management of antibiotic therapy in collaboration with various providers, I think it's essential to help educate and empower patients to make informed decisions regarding their allergy status. Today we learned that a penicillin allergy is not always forever. Alternative antibiotics to penicillins can result in suboptimal treatment and an increase in side effects, and in patients with a mild penicillin allergy, the use of a similar antibiotic class, known as a cephalosporin, may be a safer approach than alternative agents such as fluoroquinolones or clindamycin. My name is John Snyder, and thank you for your time. If you have any additional questions regarding penicillin allergies, please bring them up with your provider at your next visit.